Okay. All right. Well, let's kick off. Fantastic. So thanks, everyone. Thanks for joining us this evening for the second of these COVID Ready seminars, a joint partnership between Health Consumers Queensland and Children's Health Queensland. I'd like to start by acknowledging the traditional owners of the land which I am on today, the Yagara and the Turrbal people. I'm in Kurilpa in Meanjin. And I would like to acknowledge the traditional owners and acknowledge that sovereignty of these lands was never ceded. Welcome to our live Q&A. We are very, very glad to be able to provide you with the opportunity to provide a forum where you can hear directly from clinicians, to have your questions answered, and to receive the information that you need to make informed decisions. We have many participants who have registered tonight, and we do hope that some of them will join as the evening goes on, and we will be sharing the recording of tonight. So if there's anybody else who you know would like to receive the information, you'll be able to share that link afterwards. So thank you for your interest. And as you are aware, the topic of tonight's discussion is COVID-19 vaccination for children 5 years and older. So before we start, we've just got a little bit of housekeeping. So the session is being recorded and, as I said, will be published on Children's Health Queensland social media channels. And we'll be using the Q&A function tonight to keep the session manageable. So you'll find the button in the menu bar at the top of your window, or for me, it's at the bottom. It depends on if you're on your phone or on a laptop or computer. If you're unable to use the chat function, you can use the raise hand button and we will give you audio access to ask your question. We'll try to respond to as many questions as possible in the next hour. If we can't keep up though, please bear with us. And if we run out of time, we'll endeavour to get any questions answered and respond to any outstanding questions out of session. We'll also need to keep to the topic, so if questions wander off track, we will bring questions back to the topic that we're focused on this evening. And lastly, a reminder that our panellists are clinicians, they're not politicians, and they are not responsible for health policy. What they are responsible for is sharing their knowledge and expertise to answer your questions tonight, and we're very grateful for their time. Also a reminder that Children's Health Queensland and Health Consumers Queensland respect the rights of consumers and carers to make informed decisions. We don't expect to hear a consensus amongst consumers, carers, parents, and we know that the COVID vaccine is one of these issues, which is why tonight is so important. We would like this to be a safe space, so we ask everybody to be respectful of each other during today's session and in the Q&A thread. So without further ado, let's get started, and I'll hand over to Fiona.
Good evening. Thank you so much for joining us. I'm just watching the ticker go up to 230 people, which is incredibly exciting. I want to spend just a minute introducing our expert panelists. So we have two wonderful clinicians with us tonight, Dr. Julia Clark, who is the Service Group Director for Infectious Diseases, Immunology and Allergy Rheumatology at Children's Health Queensland. That's a bit of a mouthful. She's also the Associate Professor in the School of Clinical Medicine at the University of Queensland. Now, Julia is our infectious disease expert, if you like, in this panel, but talking to us specifically about vaccination will be Dr. Sophie Wilcox, who is the consultant immunologist and allergist at Queensland Specialist Immunisation Service, Children's Health Queensland, Queensland Children's Hospital. So they'll be our two experts that you'll be directing all your questions to this evening. But before we do that, I want to just launch a very quick touch point poll to see where people are joining us from and how you're feeling at the start of this Q&A. And the reason we're tracking this is we're going to ask you the same question at the end to see if this information has supported you to make a decision for your child. So I'll just leave that open for a moment. You can see we've got lots from Greater Brisbane and a handful from our other regions. Great to see some of our regional people joining in. So we've got some Wide Bay, Darling Downs, Central Queensland. Welcome. I'm glad to see all your internet still working up there in the Wide Bay as you recover from the floods. Hope everything's all right up there. We've been thinking of you. Couple from Cairns as well, I'm noticing dropping in. That's brilliant. Northern Queensland too. Wonderful. And a bit of a mixture in terms of the comfort level around vaccinating your children. So a number saying they're not comfortable, some quite comfortable, and others, a smaller number, saying they're very comfortable and confident. So we'll see how that is happening, if that's changing at the end of the Q&A. But whilst that poll is continuing, we've got 193 of our 250 have completed the poll. So I might just leave that open for another 30 seconds or so while people are jumping in. But in the meantime, I might kick off with a couple of early comments by our two experts. So Julia, I might start with you around some myth busting, if that's okay.
So I think it was a good idea just really to put some context around COVID and the disease in children in terms of what we would expect, so that people can really think about that in terms of their risks and benefits. So when we're thinking about COVID-19 in children, the message that everybody is giving is that most children have no or mild symptoms. And that's true, but it doesn't mean that all children have no or mild symptoms. And mild symptoms may be not mild from they might be mild from a hospital point of view, but they're not mild from a parent's point of view. So fevers, tummy upsets, sore throats, which keeps them off school. And there's a huge amount of school missing with children who have mild symptoms. But occasionally, children can get more severe symptoms. And those are particularly seen if children have severe chronic disease, so other things that they are coping with, or if they are very overweight, and that is seen also in adults as a risk factor for progression for severity. And a really important point to make, that if symptoms progress, we do have treatments that are available. And I think that has been missed out of the conversation a lot. If your child becomes unwell with COVID, we have treatments to help them not progress any further. And one further thing that is really helpful for health professionals and parents to understand is that in children, as opposed to adults, there is a post-infectious and inflammatory syndrome that it's important to be aware of. So about 2 to 6 weeks after you recover from COVID, even if it's been an asymptomatic disease, you can have this inflammatory syndrome, which can be more severe than the acute COVID. It's very rare, but very well recognized. And so there's two parts to children's COVID: a mild disease in most children and a post-infectious disease 2 to 6 weeks after recovery. Next slide, please. And there's been a lot of talk about Omicron as the new variant of concern compared to Delta, and that this may be a different producing different symptoms and producing very much more transmission. And it's certainly true, as we're all seeing now, we're all living with an increased transmission in both adults and children. It does appear that Omicron seems to be less severe. So there is some good data coming out where, particularly in the US, comparing Delta with Omicron, and it looks like there is less hospital admissions, for instance, and less severity in both children and adults with Omicron than Delta. Again, doesn't mean that there is none. And COVID, Omicron particularly, does produce a very feverish illness. So children are presenting with fever, sore throat, croup often, as well as runny nose and cough, and sometimes tummy upsets. And children, very young babies particularly, are getting fevers that last for a few days, and any fever in an infant always causes a lot of concern, both in parents and health professionals. So although they don't become unwell, the fever causes concern. And that's my facts about Omicron. Next slide, please.
Thank you so much, Julia. Over to you, Sophie.
Okay, so just a brief rundown on the key points of vaccination in this 5 to 11 year cohort. The Paediatric Pfizer or Comirnaty vaccine was provisionally approved back in early December by the Therapeutic Goods Administration here in Australia, And then following that, shortly thereafter, the Australian Technical Advisory Group on Immunisation, or ATAGI, gave the recommendation that all children of the age of 5 to 11 years should be eligible to receive and are encouraged to receive the Pfizer paediatric vaccine. We started rollout throughout Australia on the 10th of January, and certainly here in Queensland, that is going very well, as I understand. In terms of the dosage, it is different to the 12 years and above in the fact that, as we previously mentioned, it is a lower dose. So it's 10 micrograms, or a third of the adolescent or adult Pfizer dose. And the interval is different. So the current recommendation is to give 2 doses split by an 8-week interval. The data from the clinical trials for Pfizer for the 5 to 11 years, which included well over 2,000 children in the US, showed that this was a very safe vaccine, as I mentioned, with very mild and short-lived side effects, and it was highly effective at producing protection against symptomatic COVID-19 infection, including hospitalization. Next slide, please. The common question that's coming up a lot is, why should we vaccinate children, given that most do have mild or asymptomatic disease with COVID-19? And Julia has briefly touched on some of the reasons, but looking at children, there are both direct and indirect benefits to vaccination. The direct benefits, as Julia has mentioned, is that there is a small percentage of children who do become unwell, who do require hospitalization, and there are these rare complications that can be more serious, such as the inflammatory syndrome, PIMS TS. In addition to that, we know that vaccination against COVID-19 reduces the ability of transmission of the virus, and that's really, really important for children to stop passing it on to direct relatives, particularly those who are vulnerable, such as elderly grandparents, and also to peers and the remainder of the community. And I think one of the biggest reasons to vaccinate children is indirectly related to the fact that it will reduce the disruptions that can take place with schooling and with social activities and with extracurricular activities. So, we all know in all parts of Australia that school was disrupted last year, and kids were, constantly isolated at home and doing homeschooling. And I think, that has really had profound ramifications for the development and mental health of young children, and also their family members, preventing parents from getting back to work. And so this is a really good push and reason to vaccinate our young children here in Australia, and we have the opportunity to do so. So I think we should take it. And, finally, I think the other reason is we know that vaccination with COVID-19 infection, we're going to see a whole range of variants come out over time. And we know that vaccination of as many people in Australia and around the world can help reduce the likelihood of, more dangerous variants emerging, which is really important.
Thanks, Sophie. If I can just jump in before Fiona runs through the myths, if I could just remind attendees, to pop your questions in the Q&A rather than the chat, just so we can collate them and make sure that we get to them. Thank you. Back to you, Fiona.
Thanks, Mel, much appreciated. Look, we have lots and lots of questions in the chat already and in the Q&A already, and I'll run through those very quickly soon. What I would like to do, though, because I know it's coming up in our myth-busting section, and a number of the questions relate directly to the difference in communication between what's on the World Health Organization website around under 12 vaccine and what ATAGI and the Therapeutic Goods Association have said. There are a number of questions around that, and I know there's a slide coming up for that. So I might let Sophie address that one straight away if I could.
Sorry, I'll unmute. So this is what I've heard, a big myth that's spreading around the public and in social media, and I'm hoping to debunk that today. So the statement from the World Health Organization, or WHO, was released earlier prior to the results of the Paediatric Pfizer trial and prior to that being assessed through the Therapeutics Goods Administration and ATAGI here in Australia. The actual statement where this is taken from is referring to the adolescent or adult pediatric vaccine. So that's the dosage for over 12 years and doesn't specifically make comment regarding the pediatric Pfizer vaccine, given that it wasn't completed clinical trial prior to this statement being released. The other important thing that I think needs to be raised is that the World Health Organization do have a different priority to, for instance, the ATAGI, in the sense that their focus is on health equity and on aiming really to try and get the most vulnerable in the world vaccinated as soon as possible. Whereas here in Australia, we're in a fortunate position where we do have the resources to be able to vaccinate children. And so I think that's, why you'll get different advice in varying countries around the world. And that's why, not all countries yet are vaccinating 5 to 11 years.
Thanks, Sophie. That is a very popular question. So hopefully that's provided some clarity to families. I'll just move straight into some of the other questions that are in, and Melissa and I might just back and forth some of these so that we can look together at the Q&A. There is a very specific question in here that I just wanted to quickly throw to you, Sophie, because this parent has put it in both places, so clearly really wants to know the answer. Son has a history of Lanigan cell histiocytosis, has recovered. Is he okay to get vaccinated?
So that's a very specific
It is
question.
A very specific question.
But in broad sense, yes, children with underlying medical conditions, including the condition mentioned by the participant, are fit and safe to receive a COVID-19 vaccine. Look, unless children are acutely unwell, so for instance with a febrile illness, whether it be COVID or alternative, most are suitable to go ahead and get vaccinated. And in fact, children with underlying medical conditions should be prioritised for vaccination because we know that they are potentially at higher risk of symptomatic and more serious COVID-19 illness. So, I would certainly encourage, obviously, if there are any questions or concerns specifically about the individual child, to speak to your treating specialist. But in a broad sense, there are very few reasons that it wouldn't be appropriate for your child to go ahead and get vaccinated with a medical history such as that.
Thanks so much, Sophie. And that actually covers off a number of other questions along similar lines with other specifics. But I just thought if I pulled one out, we might get that response that generally, as long as the children are fit and well, that they are all good candidates for vaccine. But if you're not sure, go and speak to your GP or your health advisor. In terms of when is it okay to be vaccinated if your child has either had COVID or is at risk of COVID, close contact related stuff, how long after a COVID infection should a child be vaccinated, if at all?
So the recommendation around this has changed, and the current advice is that it is appropriate to proceed with COVID vaccination after recovery from COVID-19 infection. We do know it's important to still proceed with vaccination given that natural immunity, so immunity from a COVID infection, will wane relatively quickly, and we know that vaccination will provide longer lasting immune protection. From the point of view of timing, there is guidance out there that varies. However, what our current recommendation is that the child needs to be completely recovered, and to prevent any confusion with this post-inflammatory syndrome, which can happen 2 to 6 weeks after COVID infection, I think it's reasonable to give that time frame after infection before proceeding with vaccination. So again, as I said with the previous, speak to your treating specialists, but certainly that we do not need to wait. The previous recommendations were, 6 months or more. That's not necessarily required now. However, you do want your child to be fully recovered from the COVID-19 infection.
Great, thanks, Sophie. Now, I might just throw back to Julia, and we might actually get you to cover off on the 2 other myths that we wanted to cover tonight, because I think they actually cover a lot of the questions that we have in the chat. So if we can go to, this one first. Thanks, Julia.
Sure, thanks. Yes, hopefully this might cover off a few of the questions. And Sophie actually has already alluded to the fact that the differences between natural immunity from having COVID and getting a vaccine-induced immunity. Indeed, if you get any viral infection, you will make an immune response, and that immune response will protect you from future infection. But how much it protects you and for how long varies quite a lot. And it appears that the immune response, the natural immunity from COVID, is very variable. So some people may make a very good response, which lasts a long time, and some people may make very little, if any, response, and a response that lasts for not very long. And it doesn't seem to correlate to age or to severity of the illness that you had, although perhaps the more severe an illness that you have, the more of an immune response that you will make. And so because of this, you cannot guarantee that getting infection will prevent you to getting infection again. And indeed, in the UK, it's very well documented that reinfections are a big part of what's happening. It's also important to remember that, as I alluded to before, having COVID is not necessarily in a child. You're not guaranteed to just having an asymptomatic or a mild illness. You may get a serious infection, and you really don't want to risk that if a vaccine can produce a good immune response without any infection.
Thanks, Julia. So what you're saying is that it is a myth that it's safer to build natural immunity by getting infected with COVID-19 rather than getting immunity from the vaccine. That's a myth. Okay, thank you. And we'll go to the next and final myth, and then we'll go back to answering some more questions. So this one, and again to you, Julia, the myth, could you respond to: most children do not get seriously ill from COVID-19, so the risk of vaccination harm is not worth it?
Yeah, I think so. This is really making sure that we've got the risks and benefits sorted out in our head. And as I have alluded to, most children do not get seriously ill, but that doesn't mean all children. And so the benefits of having a COVID vaccination do outweigh the known and potential risks. And we know that the COVID vaccine, as Sophie has said, has had clinical trials involving thousands of children, and the real world data for several more thousand. So I think they're up to 7,000 or 8,000 in the US, with no serious safety concerns identified. And if vaccination can prevent children from getting COVID-19 and from developing severe disease or being hospitalized or developing long-term complications, the benefit outweighs the risks. So although, yes, indeed, most children do not get seriously unwell, it doesn't mean that all children don't. And then, of course, many children have been harmed by not going to school regularly, not being able to do their external activities, isolating from their peers, and getting anxious about getting unwell. And so preventing and decreasing this is a huge, huge benefit. And decreasing the spread, both to other children and to vulnerable adults and to vulnerable family members, is also a huge benefit compared to weighing up. That's the benefit from a non-transmission to perhaps not being so unwell. So decreasing transmission and increasing the ability of children to go to school and resume their normal lives is going to be a huge benefit.
Thanks, Julia. I think it's so important to recognise we've got almost 300 carers and parents on here tonight, and you're obviously all very engaged and wanting information to make the right decision for you. So information such as what we've just heard is really, really important to support you to do that. So thanks, Julia. back to you, Fiona, for some more questions.
Thank you. And you've answered a lot of those in those Mythbusters. So if your question has been answered by those Mythbusters, that might be why you don't hear me read the question out again. But please continue to put your questions in. We've got lots to get through, and I'm just picking them out based on how often they're asked in the time that we have. So one of those questions is around the likely side effects that we would expect to see in young children receiving this vaccination.
I'm happy to take that one on, Fiona.
Thank you, Sophie.
So from the paediatric age group, so we're talking 5 to 11 years tonight specifically, the trials that were done for the Pfizer vaccine for 5 to 11-year-olds have actually been really well tolerated. The side effects in this age group appear to be less common than the adolescents and adults, but we still do see mild transient side effects fairly commonly with the Pfizer vaccine in this age group. Of those, the most common is the injection site reaction, so a sore arm. We also are seeing reasonable rates of mild systemic side effects, particularly fatigue and headache. But again, majority of follow-up of the data from the USA has suggested these are mild, not requiring any medical attention other than supportive care at home, and tend to resolve after a day or so.
Thank you very much. That's useful information. So is that fair to say then that children who might experience any reactions outside of that is where you might look for some further advice?
That's correct. So there are a few other milder side effects that are less common, things like having a fever or chills. But if there is anything that is, more unusual, or parents are of concern in any way, then I think it's always important that they seek medical attention.
Thank you very much. And another question for you, Sophie, if you wouldn't mind, the dosage difference between what the under 12s are receiving and what the over 12s are receiving. Just in the case of, I have a child who is about to turn 12, should I wait until they're 12 and give them 2 doses of the adult vaccine, or is it safe to have 1 dose of the child, 1 and 1 dose of the adult? So what is the difference, and how would that work?
So that's a very common question that we're getting, and the main reason for the difference in dosage is more age rather than weight based. So certainly from the trials, the reason that they've chosen to assess the 10 microgram or lower dose, which is a third of the dose given to children over the age of 12 and adults, is related to the differences in the immune system in that younger cohort compared to over 12 years. With respect to the trial data on that lower dose, they did show that it led to very similar and effective immune responses to protect us from symptomatic COVID-19 infection. So, receiving the lower dose of 10 micrograms or the pediatric dose at age 11 and then switching to the adult dose, for instance, if the 8-week interval falls when they turn 12, you would expect the efficacy or the benefit of the vaccine to be the same, and there shouldn't be any untoward side effects. So generally the current advice is to get the vaccine that your child is eligible for as soon as they're eligible. So if they're 11, then now is the time to get their vaccine. And if they do turn 12 in that time, then it's completely safe and appropriate to convert to the adult or adolescent dose of 30 micrograms.
So one of the questions that's been asked in a number of ways by a few people is, if a parent has had an adverse reaction to their own COVID vaccine, does that increase the likelihood that their child might have an adverse reaction to their vaccine?
So the simple answer is no. Adverse reactions, particularly rare adverse reactions, which, from COVID vaccine, there are a small number, aren't associated with any genetic predisposition. So we shouldn't see, because a family member, such as a parent or a sibling, have had a adverse event, that the subsequent child should have any increased risk compared to the remainder of the population.
Thanks, Sophie. Another one that's been asked a number of times. There is a big difference between a 5-year-old and an 11-year-old in terms of size and weight and all of those things. How safe is it for them to be receiving the same dose, size of fibre?
So the paediatric versus the adult dosing is really based upon the maturity and action of the immune system for those age groups. It's not weight based, and in the trials they would have had some very big 5-year-olds and some very small 11-year-olds, and the whole selection of age and weight in the well over 2,000 children that were studied. So it certainly is deemed to be safe and effective regardless of your size or weight of your child if they meet the age criteria of 5 to 11 years, mainly because we're looking more at the immune response.
Thanks, Sophie. I've got a couple here. So there's some questions around the current dosing schedule. Could you describe the current space between doses? Is that different during an outbreak? And does what we're living now count as an outbreak? And are there any, similar to adults, are there any special conditions for kids which would indicate a shorter duration between doses?
Sure. So that's a great question, another one that's commonly being asked. So at the moment, the current recommendation from ATAGI is that there's an 8-week interval. So dose 1 given, and then 8 weeks later, the second paediatric dose is given. There are special circumstances where it is reasonable to consider a shorter interval between dose 1 and 2, down to the minimum of a 3-week interval between the 2 doses. And there are specific conditions, medical conditions, where that would be considered appropriate. There is a number, but as an example, a child who is on or commencing medications that suppress the immune system, where there may be an increased risk of serious illness from COVID-19, or where we want to try and optimize the response to vaccination prior to commencing immunosuppression. And there are a number of conditions where that would be considered appropriate. And I think it's important that parents in this situation speak to their child's treating specialist to see if in their specific circumstances that is appropriate. With respect to the reason for the 8-week interval, that was decided based on some evidence showing that a greater interval, so sitting between 8 and 12 weeks in the adolescent and adult cohort, is associated with a greater immune response and longer lasting protection from the vaccine. So there is good reason for it, and that's why it has been recommended by ATAGI. To move on to the question about the outbreak situation, that is a hard one, but at the moment the Queensland government are still recommending, even with the community transition that we're seeing here, that we continue to recommend the 8-week schedule, except in those special circumstances based on, the medical risk factors such as underlying medical conditions, and also we could consider the 3-week interval for other high-risk groups such as Indigenous and Torres Strait Islander children.
Okay, thank you for that.
Sophie. Oh, sorry, Mel.
Sorry. Yeah, no, sorry. I just wanted to ask a clarifying question on behalf of parents with us tonight or watching afterwards whose children or children in their care do have underlying conditions. Can they expect to be contacted by their specialists or their GPs to advise that their children are eligible in that category, or do they need to proactively request around that?
I suspect the answer is they need to reach out to their treating doctor, unless their doctor's very organised. So I would reach out to your doctor and seek some documentation to provide to the vaccine provider.
Okay, thanks for that. Thanks, Sophie. Yeah.
Thanks, Sophie. I might change tack a little bit and move over to you if I could, Julia. Now, for anyone who doesn't know, we are very fortunate to have Julia here with us tonight, who had the opportunity to go to the UK and study the paediatric inflammatory syndrome that has been mentioned earlier tonight. We've had a number of questions on the chat about that syndrome, Julia. A couple of things people want to know are things around what is the prevalence of the PIMS TS, what are the signs and symptoms to watch for in that post-COVID time space, and what is the treatment regime for PIMS TS?
Okay, thanks everyone. That's a really bad question to ask me, because we haven't got like an hour and a half for me to tell you all about PIMS, and once I start talking about it, you can't stop me. However, we try and do that in 1 minute. It is really important for everybody to understand and to have heard of PIMS. It certainly from the Delta experience and the Alpha experience before that, happens in about 1 in 5,000 children who have had COVID, and that's fairly well consistently documented in the US and in the UK, where most of this data has come from, and in Europe. The things to look out for are about, I would say, 2 to 6 weeks, usually about 4 weeks after your child has had COVID, between the ages around 4 or 5 and 12 is the most frequent ages for this to occur. So just in the vaccination window that we're talking about. And as an aside, there is some early data that does suggest that vaccination very much does decrease the chance of PIMS occurring in this age group and in older age groups. The things to look out for: a fever around that time that is not settling after a day or two, so persistent fever. Any rashes or redness anywhere in the body, any kind of rash, but usually a very red, florid, viral type rash. Red eyes, so the whites of their eyes become red, sometimes a red mouth, and feeling aches and pains, so feeling unwell. If you measure their heart rate, children have very fast heart rate at this time, and sometimes can get quite significant tummy pains. But the main things to look out for that are easy to see are rash and fever. And then do take your child to your primary care provider or an emergency room, and remember to say that they had COVID or your family had COVID if they weren't tested in the preceding month or so. Treatments are relatively well established in terms of the last year. Both the UK and the US and Europe have got good algorithms for treatments, and we start off with supportive care, so making sure we bring the temperature down and fluids. We monitor the heart rate and watch the heart and do measuring of the heart function and how sick the heart is if it's not working all that well. And then we would give any medicines to keep the heart working well. So things like inotropes, which keep your blood pressure up, and then switch off that information with steroids first of all, and usually that works very well, and sometimes immunoglobulin. After that, this nearly always switches that process off, and your child will recover and be better. If they're not, then there are further second-line treatments to damp down the immune system that we can give for any child that moves into that very severe area. Now, with treatments, children recover very well. Early on, there were documented deaths of children with PIMS. There really haven't been since we've understood this treatment regime. I'm hoping that will cover most of PIMS.
Thank you, Julia. Thoughts? Really important information. And just because your mic cut out a little bit for me, I'm just going to summarize a couple of those important points as I heard them, and please correct me if I've misheard, but the prevalence is about 1 in 5,000. Is that what you said?
That's correct.
Okay, and the main symptoms to watch for would be in the post-COVID period would be fever and anything that looks like a nasty viral rash, and potentially a fast heart rate and general aches and pains and malaise. Okay, thank you. And when presenting to an emergency department, make sure to let the registrar know that you have had a recent case of COVID in your family or in the child.
Yes.
Thanks very much, Julia. That's really good information. Lots of questions around if there have been any significant adverse reactions documented in Australia since the 10th of January related to the vaccine. So that's probably a question for Sophie.
Not at this stage, no. So it's early days, but so far we're just hearing the expected mild side effects. The only adverse event that has been noted is there has been an odd administration error. So the pediatric dose is different to the adult dose, and so it has been designed with a lot of caveats to try and prevent administration errors. But there has been the odd case since the 10th of January with the rollout of the pediatric dosing, but no other serious adverse events, and those children are currently well and being followed up appropriately.
Thanks, Sophie. A number of questions in here as well that probably relate to that around the long-term effects of vaccination in children. I know this is a very difficult question to answer because you can only study the long-term effects of something when a long term has passed, and we are in the early stages of this, but what do we know so far?
So far, looking at the Pfizer vaccine in the 5 to 11 year age group, we've obviously got the trial data of over 2,000 children. And then in America, they've vaccinated over 8 million, or they've got given more than 8 million doses of the pediatric Pfizer vaccine. So we do have data now, real world data, that is shown ongoing safety in keeping with the trial. With respect to long-term side effects and data, as you mentioned, this is a new vaccine and we don't have years worth of data. However, we do understand very well how the mRNA technology that's used in this vaccine work. And we understand that the mRNA that is the small genetic code, the active ingredient of the vaccine that is given to teach our immune system to recognize the coronavirus and generate antibody, is not something that stays in the body. So it is degraded rapidly within a couple of days. And so the concept of vaccine side effects presenting months to years down the track, looking at the mechanism of the vaccine really is not plausible. So, with other vaccines, adverse events with general childhood vaccines should be seen promptly, up to a maximum of a couple of weeks post the vaccine. We're not expecting to see, new presentations of unusual events occur months to years later.
Thank you very much. We've got a number of general questions, probably moving across to Julia again, about transmission of COVID-19, particularly among and between children. So I might head over to you, Julia, if maybe you can give us a bit more information around that. The questions are related to lots of areas of that, but I know that there are probably some things you're itching to say around transmission.
Sure. Thanks, Fiona. I've actually just popped into the chat as well, so I hope that's helpful. I think it's really, really good questions about transmission, because as the whole of this COVID pandemic, we've had a moving target of information. And so everything that we learn about for the first time, and information changes. So there is a very recent paper, an excellent paper, which has actually looked in huge detail at vaccinated and unvaccinated people and measured the actual amount of virus replicating virus. And that's very unusual for a study to do, because usually what we look at is viral load, which is what you get when you do your PCR and you get your PCR result. We're looking at viral load. This study looked at actual infectious virus and compared vaccinated and unvaccinated people. And they found that the infectious virus in vaccinated people was far, far less and went far, far quicker than it did in unvaccinated people. And so this is very good evidence that if you are vaccinated, you will transmit less. You will not transmit at all. If you've got close contact with people, you still got infectious virus, you may well transmit, but you will transmit less than you would do had you been unvaccinated. And that's crucial.
Thank you very much. Very important distinction. We have a couple of questions around the adverse reactions. I know I asked earlier around adverse reactions reported in Australia related to the vaccine. We've had a number of people ask how many deaths associated with child vaccination have occurred in Australia. So I suspect we've already answered this, Sophie, but I'm aware of a number of sort of rumour mills happening that have been, whether they're fake news or what they might be, but I just wanted to ask the direct question, do we have any reported vaccine deaths in this age group in Australia that you're aware of?
No, I'm not aware of any COVID vaccine associated deaths in the 5 to 11, nor am I aware in the adolescent age group in Australia. I'm not sure where that comes from, sorry.
I think there are a couple of things popping up from time to time, but it's good to know that that isn't the case. Can I ask a question around, I know when I had my vaccine, for example, one of the questions that they ask right before you get the jab is, are you allergic to any of the ingredients in the vaccine? To which I responded, I don't know what's in it because I'm not sure how much the layperson knows about the things in vaccines. Obviously, children in this age group tend to have food allergies and medical allergies and things like that. Is that something to be concerned about? Where can parents sort of find out information about what allergies might increase the risk or contraindicate the vaccine, or is there any such thing?
So that's another common question, and we do receive inquiries from parents and GPs and other referring clinicians about this. There is really good evidence and really good guidelines out there now to say that COVID vaccination is safe in children and adolescents who have underlying allergies. That includes food allergies, most medication allergies, anaphylaxis included, as well as other atopic conditions, which is things like asthma, eczema. There are very few reasons to seek medical advice prior to vaccination, and that's an allergy to a specific ingredient in the vaccine, which is referred to as PEG or polyethylene glycol, where if you have had a known reaction to that ingredient or that molecule, then it is worth seeking advice from your treating GP, or if you've obviously had a suspected allergic reaction to a first dose of this specific COVID vaccine. But other than that, any other underlying allergies, there's really good evidence and really good guidelines. You can have a look at allergy.org.au, which is the Australian Society of Clinical Immunology and Allergy, and they've got a guideline for clinicians, but they also have some information for parents and carers about the safety of COVID vaccine in children, even those with multiple food allergies and anaphylaxis, and they can be vaccinated as per any other child, and they don't need any special precautions, with no evidence that they're at increased risk of having an allergic reaction to the vaccine compared to the general population.
Great, thanks, Sophie. And we will have to wrap up in a moment. I've just got 3 quick questions, if I can rapid fire them at the 2 of you. So one is for you, Julia, a question about ex-preemie babies or under 5s who are unvaccinated, currently not eligible. How would the virus affect them, and what would be treatments?
Okay, thank you. Under 5s get very similar symptoms to over 5s, so we would expect fevers predominantly, sometimes a little bit of a cough or a snuffly, runny nose, sore throats, and that's probably just about it. Most under 5s don't, like most other children, don't really progress, but to more severe symptoms. The worry with under 5s, and particularly the very young children, so the under 2s or the under 1s, is that fever is recognizing it as COVID and not anything else. So remembering that other things, and we must remember that children get other things apart from COVID, and many other things can cause a fever, and young children may get fevers because of other significant and severe illnesses. So the main thing with young children, is understanding and recognizing when you're not happy that they are, it's not just a mild illness to you, that you must make sure that you seek medical attention, because that fever doesn't necessarily mean that it's a COVID fever. It may be something else.
Thanks, Julia. And then finally, for you, Sophie, 2 questions. So one is, when might 5 to 11s, 12 to 17-year-olds be eligible for boosters? Is that on the horizon? Do they think that that's a part of the schedule for those age groups yet, or are we not there yet?
I usually find out the updates and the changes as soon as parents find out or it comes on the media. So look, there's no suggestion at this point in time that has come out guiding us to recommend boosters for anybody under the age of 18. So currently, anybody under the age of 18, it's recommended a 2-dose course without the booster shot. And look, that certainly may change. The guidance is changing day by day and week by week. So, keep your eyes posted on this, but certainly I don't have any early information to say this is something that's being recommended soon.
Sure, thank you. And then final questions is around access. There was one parent in the chat who'd had their child's vaccine booking cancelled. And there was also a question around where kids with special needs can get access. They have contacted CHQ but haven't heard back. What's the best way for parents to get the support that they need, given everything that's unfolding in the health system at the moment and lots of competing priorities?
Sure. So, I think this is a relatively new rollout, in the last couple of weeks, and some of it has been in a staged fashion. So I do know that as time goes on, we're getting more and more clinics, so GP clinics, pharmacists, and also, big vaccination hubs opening up spots for this age group of 5 to 11 years. So what I would say is don't give up, and to make sure that you keep checking on the COVID vaccine booking website, because new spots are becoming available. If you check in the morning versus the afternoon, you'll likely find a different appointment. In terms of the 5 to 11 year age group, it's not available in all clinics. So there are certain hubs where you can get a paediatric vaccine, example at the Queensland Children's Hospital or the Convention Centre. But it's just about clicking on that website and selecting the 5 to 11 year Pfizer group and looking at your location. With respect to the special needs, it depends exactly what the parent is asking there. If it is relating to questions regarding, needle anxiety or needle phobia and getting support for vaccination, there are plenty of resources online to look at that, to try and assist your child if it's, a mild degree of anxiety regarding vaccination. If your child has attempted vaccination or is really needing additional support, there are services out there. So the Queensland Children's Hospital does have a service to support COVID vaccination in children with needle phobia. Obviously, that we're getting lots of those referrals, so that may be why this family are waiting, is that there is a wait time for that. So, there are certainly some GPs will be able to offer some additional options with things like distraction techniques that are available. But if that's already been sought, then I suggest, considering referral to somewhere like the Queensland Specialist Immunisation Service, being mindful that sometimes that will take some time just based on demand at the moment, unfortunately.
Thank you so much, Sophie. If I can throw one very final question in, there are a number of families asking, if children's COVID infection is sometimes asymptomatic, is there a danger in having them vaccinated while they unknowingly have COVID? Should we be testing children prior to vaccination?
That's a tricky question, but I think ultimately, from the point of view of your child getting the vaccine, and is it safe to give the vaccine, as long as they're not mounting a fever and they're otherwise asymptomatic as suggested, then I think there's no risk to giving the vaccine. And unfortunately, we don't have capacity to test everybody prior to vaccination. So we have to prioritize who we test and when we test. So I think, in that situation, it's appropriate to proceed with vaccination.
Thank you very much. We've reached about the end of our time. We've got 1 minute left, and I'm just going to relaunch that last poll. Just one question this time, asking you around your comfort level about vaccination. We're just trying to ascertain, has this Q&A provided information that's helping families to make decisions? We understand we haven't got to every question. We were trying to group them in terms of thematic questions that are being asked a lot. If there are important questions in here we haven't addressed, we will try to follow those up as best we can, but a recording of this session will be made available and the link will be posted, so you'll be able to watch it later and share it with your friends and family. So for a number of people who joined later on, I noticed some of the questions coming up had been repeated. So there were questions, for example, around long-term fertility and menstruation outcomes for children who are vaccinated, again relating to these long-term vaccination outcomes that we just simply haven't had a long enough term to study. But from what we know, Sophie, very quickly, we're almost out of time.
Sure. So just the question about fertility.
About those long-term effects, particularly on hormone levels for children, yes.
Sure. So
Sophie, can I ask? I have also heard some health professionals say that if there are long-term effects to a vaccine or effects to a vaccine, they're generally seen in a certain window of time rather than long-term. If you could address that as well.
Sure. So I think, Melissa, what you're saying or what you're asking is in terms of onset of side effects. Yes, you should after a vaccine see adverse events or side effects occurring promptly, and certainly, we usually expect within days, maximum weeks, certainly not, past 2 months after the vaccine is given. With respect to the fertility question, that is a common myth that has started with the adult COVID vaccination program, and they've done a lot of work to study whether the COVID vaccine could be causing any impact on male or female fertility, and that's a range of COVID vaccines, so not just the Pfizer vaccine, and they haven't demonstrated any impact, even in women who are undergoing fertility treatment, who have received the COVID vaccine, have not had any reduction in their fertility noted. There is some reports of changes in menstrual cycles with females receiving the COVID vaccine, and that's also been looked at and felt to be related to stress associated with the process of vaccination. And when I say changes to menstrual cycles, I'm talking about changes to the frequency of cycles or the length of cycles, rather than any more sinister changes. Hope that answers the question.
Thank you very much. Really appreciate squeezing that one in at the end. I understand, with children in this age group, they are prepubescent and something that most families are wanting to, make sure that we're not adversely affecting. So really important question to have answered. I'm going to share the results of that last poll, and very encouragingly, we've got more families suggesting that they feel comfortable at the end of this Q&A with their decision making around vaccines and around vaccinating their children generally. So that is a testament to your excellent advice, Sophie and Julia. Thank you so much for joining us tonight, and I'll hand back to Melissa to close the session. Thanks, everyone.
Oh my goodness, you'd think I'd know how to drive Zoom by now. Thanks so much, Fiona, for co-hosting with me tonight. For those of you who don't know, Fiona is the co-chair of the Family Advisory Committee at Children's Health Queensland, and I'm Melissa Fox. I'm the CEO of Health Consumers Queensland, and it's been our absolute delight tonight to host this session for all of you who are so passionate and engaged in making the right decisions for you and your families. Thank you so much, Sophie and Julia, for your time, for your expertise, for your openness. We're really, really grateful, and we do encourage those of you who feel that your questions may not have been answered. There's a post on the Children's Health Queensland Facebook page from a few days ago that was calling for questions for this session. Feel free to pop back to that and post any there, and we'll attempt to have them answered. We're also super keen to have a session soon around caring for your young ones and each other if COVID enters your family home. So please keep an eye out for that so that you can get the information that you need. Speaking of, there are some resources that we've got up on a slide at the moment, which you can find if you go online. So there's lots of wonderful resources for you and your families around COVID transmission, COVID care, the vaccine, and some really cute resources for kids as well, just to help support them through this time. So I think that's about it from us, but thank you so much again. Please share the link when you get it. It'll be on Children's Health Queensland's Facebook page. Stay safe. Together we will get through this, and we look forward to seeing you soon. Thanks, everyone.
Thanks, everyone, and thanks, Damien and the team at CHQ for all your support.
And thanks, Rima and Susan.